Welcome to the ACPOHE Physio at Work podcast. In this podcast, we shed light on occupational health physiotherapy and the important work physiotherapists undertake in private and public organisations, in education and in society in shaping the health of Britain. It's a limited series of maybe 10 to 12 episodes, during which time we'll be talking to experts in their field of work. And today's guest is Paul Shawcross, who is an occupational health physiotherapist and ergonomist. He's a lecturer at Coventry University. He has worked as a specialist musculoskeletal and occupational health physiotherapist for nearly 15 years. Been supporting different people and organizations in managing musculoskeletal health, pain and well-being. So his clinical interest is helping people with long-term pain conditions to help them return to function and help them be able to do the things that they want to do. And in his role at Coventry University, he enjoys developing the workforce of tomorrow and mentoring already qualified physiotherapists, which is very, very good. We need more people like Paul, I think. We would like to achieve a few objectives today. We would like to understand the fit notes and what it is and who will typically provide fit notes, the importance of them in terms of UK absence, data and health. Be awesome to understand the limitations of the current system. And I believe that Paul has done some research here that we're going to talk about. There's been a new reform that's been announced in May 2026. So we want to talk about that and also to understand why work is good for people. Often not well understood, work and health goes together. And then also we would like to understand the behaviors, knowledge and skills that's required by us occupational health physiotherapists to understand why we are perhaps very well placed to provide fit notes. And we're going to do a focus here on the need for clinicians to be completing fit notes. And also we need to talk about the risk of non-clinicians completing them, because I believe there's some talk about that. So Paul, thanks for being on our podcast. It's good to see you.
Morning, Lasse. Yeah, thanks for having me. Good to be here.
It's a long intro. I've been thinking maybe we should shorten that down. So I will work on that for our next podcast. Now, if you wouldn't mind, perhaps start us off by talking a little bit about yourself. Where do you come from? Where did your career path start?
Yeah, sure. So I have always lived in the UK. I'm from kind of Stockport, South Manchester way originally. Moved a little bit around the UK, a bit of time in Leeds, and now live in the Midlands in Northamptonshire. In terms of career, yeah, so I first did a degree in sports science and physiology, and then did the 2-year pre-registration master's route to get into physiotherapy straight away, because I knew that was at the time that was what I wanted to do. Now, when I qualified, it was a bit of a rubbish job market, a little bit similar to what it's starting to get like now, I think, because it's not great at the minute for newly qualified physiotherapists. But it was really bad then. So we were all struggling to get jobs really, and a lot of people that I qualified with went into different things. But I managed to get a job at a small private organisation that maybe had about 8 different sites around the kind of Cheshire area, so and into Staffordshire, and actually managed to fall into occupational health quite quickly. They had a couple of big contracts. Probably the biggest one I got involved with was with Bentley Motors, and that was an on-site clinic, and it was a great place to learn my trade, because they did quite a lot of ergonomic type interventions and training for some of the staff there and things as well. Now, with it being quite small,
all hand-built cars, right?
Exactly that. Yeah, hand-built cars. Really interesting, actually, just watching how they did it there, because it was kind of short. It was all hand-built, but and quite, I think they call it tap times in car building, but quite long tap times at Bentley compared to other cars. We spent the time on them. So it's interesting just walking around the factory. You had lots of celebrities visiting as well that were having their bespoke Bentleys built. So yeah, I had a funny story actually. The first time I went on site, I didn't know where I was supposed to park, and I had a Nissan Micra, really old Nissan Micra, and I was driving round the Bentley site. We're getting funny looks, and then the physio that I was going to meet there was like saw me with a panic look on his face and was like, "Get out! You're not allowed in here in your Nissan Micra." And I misunderstood where I was supposed to be parking. So that was a nice introduction to it, but yeah, and a really interesting place to work. And I got kind of thrown in at the deep end, just the way it was then, I think, and got given a lot of responsibility quickly. And luckily, I think I was swimming against the tide, but I did manage to stay afloat and learned lots through doing, really, just getting involved with lots at the start, and was very independent quite quickly, probably more than I should have been. And actually quite quickly became the lead of their occupational health service after a couple of years.
The entire occupational health service?
Yes, I mean it's a small company, so they did have some big contracts, Bentley, Michelin tires, some councils, they had a few big contracts. But yeah, I was ended up leading it, 2 years qualified, which was interesting, but learned a lot through doing that. And after I've been there for maybe 3 years, I felt I was struggling a little bit, more because of the amount of travel I was doing, I think. So decided to leave and went to a slightly bigger organisation, which no longer exists actually, called Connect Health. And took a step back, just went to a senior physio role, which was nice for maybe 6 months or so. And then I think I started to get a bit bored. So then worked my way up the chain there, and then headed up the occupational health service, which was much bigger there and was very national role, which again, great experience to do that, and did that for a number of years, probably there for about 6 years, I think. So learned lots through that process, and they developed me really well as a clinician, as well as in that area. Lots of leadership training and skills that I got from that as well. And then that probably took us into the pandemic, I think. And when we were coming back out the pandemic, I had kids, and the national role in traveling around the country and trying to look after kids didn't go hand in hand. So I decided to leave at that point, and I'd always fancied working in education. So got a role up at Salford University, which was great actually. It was an interesting time to come into it, because it was when just after the pandemic, and placements were in an absolute mess, as you can imagine, and may have heard at the time. So I was brought in actually as the placement lead, jointly with someone else, to try and sort that mess out, whilst also learning my trade in education. And it was a really good time there. Yeah, I was only there about 20 months because I moved, but really good experience there. And then I moved down to the Midlands, carried on that career just at Coventry University, where I've been for just over 3 years now. And about a year ago, I dropped a day there because I was starting to miss some of the stuff in practice. So started doing some consultancy work back in occupational health, workplace health, chronic pain type stuff. And I've really enjoyed that. I've been back to it in the last year or so.
Yeah, that's really interesting. My first impression of the UK was Coventry, so I moved there in 1998 from Norway, and did three awesome years in Coventry. A lot of fond memories, no doubt. So we're going to talk a little bit about the Fit Note today, and you happen to be the right person to talk to about this, I believe. So I guess it'd be helpful just to, first of all, talk about what the Fit Note is. What is the Fit Note?
Yeah, so I suppose it's probably worth me briefly going through the history of it, because some people might still recognise it as the Sick Note, which it was prior to 2010. I think the name was changed, so 16 years ago. But the Sick Note has always been used as a legislative piece of paper, really, in the UK to originally sign people off work as sick, and make them eligible for things like statutory sick pay and things like that. Now I think it was changed in 2010 to the Fit Note to try and try and have some more positive language in there and try and get it used more to support people back into work, and suggest what they were fit to do, as opposed to just sign them off work. That was the idea. And I think maybe it had a small effect, but not as much as the government maybe were hoping at the time. And there continued to be an issue really in this country, with sickness absence on the rise and more people not in work due to health issues and other issues. So they did create, I think it was maybe around 2015, 2013, they create a new report which was called the AHP, so Allied Health Professions Health and Work Report. And this is like a slightly alternative version of the fit note that could be completed by physiotherapists, podiatrists and occupational therapists. So the CSP and RCOP for OTs and podiatry's professional body as well were involved in creating that. And that was created as an alternative that people could use rather than just having doctors who would traditionally complete the fit note. But again, people didn't really know about that, and it's probably didn't change practice that much. So there was then a big legislation change in 2022, and that was to change or expand who could complete the fit note. So it wasn't just doctors; they added it. So there was 4 other professions, and off the top of my head, that was physiotherapists, occupational therapists, pharmacists, and nurses.
Interesting. With the pharmacists as well.
Yeah, pharmacists too. So when they're reviewing people for medication, can complete them as well. So there's 5 professions now that can complete fit notes, and that's been the case since 2022. And then we can talk about how it's all been and what's coming next shortly. But yeah, that hopefully gives you just a little bit of the background of it.
I find that quite interesting. And in terms of, let's say, a pharmacist, or perhaps closer to the what we are talking about today in terms of physiotherapists, could any physiotherapist write a fit note? Yeah,
it is interesting because there is training available. I think when it was first changed, the DWP who oversee it, Department for Work and Pensions, they created some training which was quite generic for any health profession. But the Chartered Society of Physiotherapy, the CSP, they also created some training, and I think there was a bit of collaboration there as well. And but there wasn't like a requirement that you had to do that training to then go and complete a fit note. It was there as we advise you to do that. But essentially, legally, any physiotherapist since 2022, I think it's July 2022, can complete a fit note. Yeah. People haven't necessarily because of time, not feeling competent, pathways at work and things like that. But yeah, in theory, we can all complete them.
I think that is very interesting, and I would be surprised to see that a lot of people would not be aware of it. Or I'll be reasonably certain that this is actually news to many people. So what you're saying is physiotherapists can write fit notes. If someone wants to come and see you as a patient, whether you're a private physiotherapist or work in the NHS, and you believe they are either fit to be at work or unfit to be at work, you can write a fit note.
Yeah, absolutely. I think my advice for anyone that's listening would be obviously have the conversation within your service about how you want to do that, rather than going rogue and just starting writing just starting filling them in. And different services are doing it in different ways. But yeah, legally we can complete them.
That's great. And in terms of where that would legally stand then, so let's not talk about occupational physiotherapy right away, but let's say an NHS physiotherapist or even a pharmacist, let's say, were to write a fit note. However, GP wants to write another fit note and there was some conflict between the two. Where would they stand, I guess, in terms of legal weighing?
So legally, there isn't really any requirement for anybody to follow the advice that's on a fit note. It's all advisory, so it doesn't matter who completes it, whether it's a GP or it's a pharmacist or it's a nurse or a physio. The advice on there is all advisory. So the person can choose to ignore it if they want. The employer can choose to ignore it if they want. And I think that's really important, because I think that people get worried about that, in terms of, where do I stand? You know, if I give the wrong advice, or this doesn't quite work out, where do I stand? But yeah, it's up to them to follow the advice and to apply it in the best way that they can. As an example of that, you know, I might often put in a report or footnote that I'm writing that this is what I think would work for this person based on how they're presenting from a clinical point of view. But I do understand, or I am aware that this might not be practical from a workplace point of view. So you're giving clinical advice, but I think we often use the term as far as reasonably practicable. And what that means is that if you're able to do this, this is what we recommend. But the great thing is it sparks a conversation, between them. If they can't do it, then at least they're aware of the person's limitations, and they might have an idea, and they can have that conversation with the person then about what they might be able to accommodate.
Okay, so just a little bit about the nuts and bolts then. I guess for those of us that might not know where to look for the document, the FitNote document, where can you find it? How does it look?
Well, that's interesting, because I think we'll come on to the research that I did, but it was all about physiotherapists, and are they aware that they should be completing fit notes? Are they completing fit notes? If they are, then what's enabling them to do so? And if they're not, what are the barriers to having to overcome? And actually, one of the biggest barriers is access to the fit notes. Although we can all complete them, getting hold of one could be quite a challenge. So I think my current understanding is that you can get it on a couple of the NHS systems. So EMIS and System 1, I think, are the two systems, but it might only be on certain versions of those systems. And if you're working in private practice, it's virtually impossible to get a hold of one. So it's much easier if you're in the NHS. And when I tried to get hold of one for training purposes, because I was developing a training package for the CSP a few years ago, they were on about sending me one via fax. It was a bit bizarre, really, in terms of the digital enablement there. It felt very behind. So I'm probably not quite as on top of that in the last year or two, but I don't think anything's changed. I think it's still really quite difficult to get hold of. Lots of paper copies that you can order in and things like that, but digitally there's work to do.
So could you just go on Google, let's say, and search for the fit note, find a PDF, print it out, and
no. So you couldn't. So you might find something that have got something plastered across them, like trial version or training version or something like that, but nothing you could actually use in practice. That's the challenge. You can. So the other report I mentioned earlier, the AHP Health and Work report, which physios, podiatrists and OTs created, that's around. That can still be used. Legally, it's pretty much the same as the FitNote. The only difference is that you can't use that for if someone's claiming ill health benefits. The FitNote can be used for that to support their case for claiming ill health benefits, whereas the HP Health and Work report can't be used for that. But you could still use it for statutory sick pay and sickness absence and evidence that you're unwell. And that is available as a really nice interactive PDF that someone could just go and get hold of. So that's an option for people, I suppose, at the moment, whilst the DWP are working out how they're going to make it a bit more digitally accessible.
It is interesting that I presume at some form of central leadership level in the UK state, we've been allowed or given the opportunity to create fit notes as allied health professionals, but also simultaneously there's a restriction to access to the official form to use. I find that somewhat peculiar.
It feels like they've said, yes, you can go and do this. You can go and do this, but we're going to put some handcuffs on. It's bizarre, isn't it?
Yeah, a little. Yeah. I mean, I guess it's perhaps beyond the podcast today to discuss the reasons for that. Have you got any theories? Or
Don't know. I did have some conversations with some senior people in the DWP a few years ago when I was trying to get hold of it and was talking about, look, we're developing some training for the CSP, keen to collaborate. They were open to meeting and things, but they were very cagey about using it outside the NHS and wouldn't really give a reason. And it just sounded like it was very policy driven in terms of that any changes will be slow. And they were working out what to do, and this fit note reform that's coming in now, which we'll talk about a little later. That's very similar again. It's they're looking at some changes, but it's all very slow, and a lot of discussion around things happening rather than a lot of doing. So yeah, I'm not fully sure why they've been so restrictive over it. Maybe they're a bit worried about it going rogue. I think they were a bit worried. There was one conversation I had about people getting hold of fit notes and maybe not using them in the right way. And I was a bit like, well, isn't that the problem at the moment, that it isn't being used in the right way? And why are we being so cagey? Let's go for it. But yeah.
Perfect segue, because my next question is the current fit note system working in terms of managing absence and sickness in the UK?
No, I think in short, I think that's the obvious answer. I mean, there's other things at hand here. It's multifactorial in terms of the absence in the UK. I think the fit note's not just to blame. But yeah, I mean, I've got some data for you here. After the pandemic, the sickness absence would really hit a peak. So in 2024, I think the data was that 9.2 million people of working age, so between 16 and 64 in the UK, weren't in work and they weren't looking for a job. So 9.2 million, if you think what's the population of the UK, about 70 million. So it's a huge proportion, isn't it? Huge percentage, more than 10-15% of the population not working nor looking for a job. Now, not all of that's due to health issues, but a good third to half of it, I think, is. Mental health being a big cause, musculoskeletal pain being a big cause. So huge numbers. I think it's got very slightly better since then. I think it has dropped slightly, but it's still kind of up towards that 9 million mark. And just a huge issue.
It's a concern.
Yeah.
That's a lot of people outside of work.
Yeah.
I feel there's so many ways we can, what the next thing to move on to from just that statistic alone.
Yeah.
But I guess it would be useful just to really quickly touch on why work is important to people's health very briefly at this point.
Yeah.
Yeah.
A lot of work been done into that again through the government. I think it was more Public Health England that did this, and they did this piece of work where they call work, or can think about work as a health outcome, which was for health professions to think about just someone's presence at work itself as a really important outcome for health conversations and health interventions. And they used all the data to justify that. And something that stuck with me is that there's a really nice kind of, I suppose, cycle to think about with work. And it's when people go off work, if they are signed off for an extended period of time, they then have all of these other things that happen. We often talk about the biopsychosocial model of healthcare, and there's biological stuff that happens to them in terms of they're probably less active because they're not getting out of bed and going to work, which is going to have detrimental effects physically on their health. They lose income. So socially, they might struggle to pay bills, might have housing issues, the negative effects potentially with family and things like that. And then there's a psychological thing as well. I mean, if you're struggling with those things, you're probably likely to lose confidence, self-esteem, potentially go down that cycle of anxiety and depression and things like that. So it has a huge impact on the person, and that makes it really hard then for them to get back into work because they've then got all of these health issues to cope with. So there's this kind of negative spiral that happens when they're off work, and it's all triggered by not being in work and not having that structure. I think I'd always look at work and think it gets us out of bed, it gives us meaning, it gives us money, which then helps us to do the things we want to do. We can do the hobbies we want to do, go on the holidays we want to do. We can interact and socialize with people. Take that away, it's really challenging. And I remember doing a piece of work actually just at the start of the coronavirus pandemic with the DWP, which was about helping people that they've been out of work for more than a year or two to get back into work, and had some really interesting conversations. And one thing that stuck with me was people telling me that when we went into the lockdown and they weren't allowed to leave the house, weren't allowed to socialize, weren't allowed to go anywhere, they didn't have to change anything about their current life. They were already so isolated socially from society because of their lifestyle, because they weren't going out to work, because they didn't have any money, because they were struggling with their self-confidence and esteem, so they weren't seeing friends and family. They didn't have to change anything. Going out of the house for 30 minutes a day was quite normal for them, and maybe more than they were used to. And I think that hits it on the nail on the head for me, of that's what happens to people if they haven't got that meaning in their life. And work, when we're between 16 and 68 or whatever retirement age is going up to, it's a huge part of our lives, right? It gives us meaning, makes up a lot of our time. And if we can intervene and keep people in work, it improves all of those things. It gives people confidence. It allows them to socialise, gives them money, and has a really positive effect on their health.
But all of those things are also directly correlated with, they correlate both ways. So if you're off work because of ill health, it might be tricky to get back to work, but it works the other way around as well. So being off work drives further ill health. And I find this interesting. I don't have the statistics right in front of me now, but people look forward to becoming a pensioner, and they like the idea. I mean, I will admit it, I like that idea as we speak, working towards, finally getting off the bandwagon as far as work goes. However, and retiring is actually quite a significant risk to people's health and well-being. And I'm sure many people who listen to this podcast will know firsthand of people they know of that retired, and that's where ill health with those people started occurring. I can think of several people in my own my group of friends where that's happened to, and it's quite shocking. In fact, that's made me think of the possibility of never retiring. If we want to live a long and healthy life, having that in the back of your mind, that maybe carrying on working to some point for the remaining of your life might be a really good way of extending your life and your health.
Definitely. I think I'd agree with that. There's a lot of people, isn't there, that once they retire, that is, like you say, it's almost like the start of that decline for some people. And some people find meaning, and I think that's the key, isn't it? Of whether that's through hobbies or traveling or volunteering. I know a lecturer I used to work with went and started volunteering locally in like a grocery shop, and things like that. I think you need that meaning. That's the key, isn't it? Whether it's work or something else, you need that. And if you've not got that, it's a real struggle, isn't it? Real struggle. Yes. What's getting you out of bed? What's keeping you active? All of these things that we, all these lifestyle things that we know are good for our health, like physical activity and preparing meals and eating healthily and sleeping well, and all of these things. You almost need structure to do those things, and if you haven't got it, it can be a downward spiral. So yeah, definitely hugely important.
Very interesting. So I feel there's a couple of things that when we were talking earlier, I was thinking all these questions I have in mind I want to ask you, but there's no perfect way of doing it. So I'm going to just go back one step and talk about the nuts and bolts of the fit note.
Yep.
We've established it's hard to come by, but we can absolutely write fit notes as physiotherapists. But in terms of what do we put onto the fit note, we haven't established that. Is it possible for you to tell us about it? What would a fit note entail insofar as information goes?
So it's quite, to be honest, it's quite easy to fill in once you know how. There's a few boxes that you tick. So there's a first box where you'll put in very briefly what what the person's health condition is. Now, remember that we're writing this, a fit note. It's not a medical document in some sense. We're writing it to the person themselves and to their employer, who are likely not to have health background. So it's very much basic language that we're using. So you're going to be talking about low back pain as opposed to a lumbar radiculopathy, for example. And you only need to briefly put what their condition is. And then I think the next box under that is either ticking whether they're fit for work, they're not fit for work, or they might be fit for work, taking into account the advice that you're going to put below. So those, which box you tick there is key, because either they're not fit or they might be fit. And then under that, there's another few boxes of things that you could suggest. So like a phased return to work, or a change in duties, or that they might need a workplace assessment, some further investigation in the workplace. So you can tick one of those boxes, and then there's just a small box for you to put a bit of advice, and then you sign it, and that's it, really. Now, that box is obviously the most important bit in my eyes, but it's often the bit that people don't complete. And that's the problem, I think, is historically, most people will use a fit note to tick the not fit for work box, and that is it. Don't complete anything else. And in fact, just to give you some data on that, I think historically that's been well over 90% of fit notes are marked not fit for work. I think it was more like 95% maybe before the changes, and it's improved slightly to about 90%. But 90%, this is 2025 data, so last year, 90% are still ticked as not fit for work. And that might be fit for work box is only ticked 10% of the time.
It's mad.
Which is mad.
Yeah.
It's mad. But the good news is, and I suppose where physios and other professions are maybe doing well, so doctors are still completing most of them. Probably about 90% are still completed by doctors. Nurses, about 7%. Pharmacists, physios and OTs probably make up 1% each. So it's not much that we're completing. But when we are completing it, physios tick the might be fit for work box more than any other profession. So about 30% of the time. And OT is very closely behind, 27%, I think, on that data, which is NHS digital data. So we're not completing them very much. It'd be great if we're completing them more, but when we are completing them, we are completing that might be fit for work and giving advice more than other professions, which is great.
It sounds also, when you're describing the way to fill in the fit note, it sounds like a small version of the typical occupational health physiotherapy report that I will write for employees that I will assess, which tend to be a bit more extensive. But would you agree with that, or can you see a
it's
significant
quite brief,
difference?
Yeah. So you could be putting in that box that, look, this person might be fit for work if they can avoid this particular task that they're really struggling with because of this shoulder issue and they're struggling to reach overhead. But they can do everything else with their job. It's just that one task. And if they can avoid that for the next couple of months whilst they work on the rehab, then they should be able to return to full duties. So it doesn't need to be much in there, just a brief paragraph to explain.
It's super interesting. I would like you to talk about it, but I feel like I would want to sort of interject about the sort of role that we do as occupational health physiotherapists. And I'm thinking that we're in such a fantastic position to be taking a lead, certainly on the musculoskeletal side of things, and certainly for those organizations who have physiotherapists working in the workplace. I mean, in your view, how do you see occupational health physiotherapists being placed to take the fit note on and to drive it forward in their workplaces?
Yeah, I don't know really. I think occupational health therapists have obviously got the skill set to go and just do it. Equally, I think a lot of occupational health physiotherapists are already embedded in organisations and completing maybe slightly different reports, and they're used in a proactive way already. So in a sense, it's like, well, that's already great and that's happening. It's almost how do we get the masses as well, and the fit note is the obvious way to do that, and maybe how can we get more clinicians skilled enough and confident enough to just be able to do that. I think that's probably my view, and OH physiotherapists could maybe be there as mentors or training support, whatever that looks like, because they've already got the skill set. But I do think it's looking beyond that, and I obviously teach at university now. I've tried to start embedding some of this into the curriculum there and get even physios that are coming out as graduates exposed to it, go through a little bit of training with them on how to use a fit note, so that when they're coming out, they've already got a little bit of that skill set and they can start to bring it into just normal practice. And that's what I would love to see. I don't think it's just MSK, even musculoskeletal. I think, wouldn't it be great if someone had been discharged from hospital with, I don't know, just after an operation or another health condition. I had Guillain-Barré syndrome a couple of years ago, which is a neurological condition, quite a rare neurological condition. The fit note that I received as I was discharged was just how long do you think you need off work, and it was just like, yeah, you can have a couple of months, there you go. And it was just like, yeah, but I probably don't need that long. And also, what could I do? What would be like the way of phasing me back into work? And obviously I was skilled enough to kind of do that myself because of my background. But I was like, wouldn't it be great if we could get people that were skilled? And when people were discharged with these things, there was almost like, well, you're going to struggle with this for a few weeks. I had very much lower limb weakness and had to retrain my legs to walk again, and was on crutches and stuff when I came out. But wow, I could work from home quite fairly soon after. I could, it was only a month probably after that the rehab worked enough for me to be able to walk independently again. And then I could, start to work on that. I had some fatigue to manage, so phasing back worked really well. But yeah, wouldn't it be great if we could just get more people that were looking at that when they were discharged from hospital, as well as more MSK stuff?
That sounds brilliant if we could do that. I think it's also at the hospital level and at primary care type of level. I think having people in the right positions to drive and to fill in appropriate and good fit notes is good. But I think also really at the level above, at the the point that you made in terms of having access to the notes alone, it just seems madness to me. So it seems to me also that there needs to be some form of positive influence at that level, some sensible minds with a occupational physiotherapist ends that could be in a position of guiding and advising whoever the levers are in the system that is limiting appropriately using this type of fit notes, because I do think we're alluding to it, that perhaps the current system is not working very, very well. And it's largely GP led. And fortunately and unfortunately, I think I will say this right away, Paul, I think GPs are under a great deal of pressure when it comes to this. And they have busy days, busy lives. However, if someone was to come in and the filling in a fit note, the simplicity of just ticking non-fit and just 4 weeks, just out of my hair for 4 weeks, because you got hundreds of cases that are much more important, and there's life and death scenario and so forth, on top of it being a really, really busy GP surgery. I can see it's just going to be hard to handle and manage effectively just from a human capacity perspective.
Yeah, it's interesting. So when I was back in Manchester a few years ago, NICE, National Institute of Clinical Excellence, who create a lot of the guidelines in the UK, they were doing some work on this. And I was able to go along and observe some of the conversations. There are the various experts involved in the conversations. And it was really interesting because we were looking at what are the barriers for GPs. And the things that came out of that was, it was quite clear, really. It was time and confidence and competence. So interestingly, GPs don't get training. They don't get trained in how to complete a fit note. They just expected it's part of their role, which I think is probably the case for a lot of their skill set. And they don't get time. I think what's the average? About 7 minutes. that they have for a consultation or something ridiculous like that. So to truly understand someone and then complete their fit note, and they're probably there with multiple health issues and referrals and all the other things that they have to do, it's just impossible. So I think it's great to expand it beyond GPs, to take the weight off them and have more people doing it. I think we really just need the shackles off, don't we? And just have it as a tool that people can use. But
Interesting. The other thing is the policies of companies. So larger companies will have their own, well, most companies will have their own sickness policy. And most of the time, a GP written fit note sits embedded in the policy wording alone. So even if they have a physiotherapy service on site who writes, oh, this person is fit for work as long as A, B, and C happens, well, if the person's been off work for longer than a week, they still will need a GP fit note. It's advisory, but even so, they still need it just to tick that important box in terms of having sick money and for things to like fit into the matrix, you know.
Well, that's the big one, isn't it? Statutory sick pay. They need it for that, and that's UK-wide policy, isn't it? So I don't think that will change unless policy change. And I do think that is a key area that it's difficult to change things unless it changes at that policy level. I think that, like I said, the research that I was involved with, in that research we did some surveys, but we also did some qualitative focus groups as well, so discussions with people, and I think we got over 400 physios for this study, which is the biggest piece of research that's been done just to look at this in the UK. And it was interesting because that was such a barrier. I think there was 89% of the participants did feel that talking to people about work, advising people about work was part of their role. So people are on board with it as part of their role. But about 31% were actually issuing fit notes. And bear in mind, this is probably people that volunteered for this have probably got some knowledge and interest as well. So it's a probably slightly focused group of participants that have got some awareness already. But only 31% were completing them. And the main barriers were organisational barriers. So there was no pathway developed in terms of when do they complete a fit note, who does it, how long do they issue them for, when do they review. These kind of things just hadn't been discussed at service level. Access was probably the biggest one. Again, the time and the confidence to do it, similar to GPs, was the other one. And then patient barriers was the other big one, because patients didn't have the awareness that they could look beyond the GP. That campaign's never been done, in terms of, you don't have to just go to your GP now for a fit note. You can go to all these other health professions. So patients asking for them still tend to go to a GP. So, there seem quite obvious barriers, and it needs a probably campaign policy to support that, more training and mentoring and things like that. They were kind of the enablers that we recommended from that paper. But that was published earlier this year. We actually did the research a couple of years ago, because it takes a while to get it to publication, and I've not seen much change really in the last couple of years, and I guess hence why they're looking at doing a new reform and going a different way. It doesn't quite fit with our research, though, the direction they're going in.
Could you tell us a little bit more about this reform? I think, was it in May 2026 that?
Yes, last about 6 weeks ago, I think that this was announced. And what they're looking at doing with these reforms is they're doing 4 trials, or pilots, I guess you'd call it. I think there's Birmingham and Solihull, so your kind of neck of the woods, Coventry and Warwickshire, which obviously is around where I work, Cornwall, and then the other one's Lancashire, South Cumbria area. So there's 4 regions they're going to trial it. And they're looking at, I don't know if you've heard of WorkWell, which is a government intervention they've been trialing for a couple of years now, which is about trying to combat this problem we've got with so many people being off work, and trying to get some more early intervention to support people to get back to work well. And they've only done it in certain regions, but they're looking at combining the two things and basically embedding the fit note within this work well program. You look confused, so is it worth me just telling you a little bit more about the work well program? It might be
Yes,
useful
please
for the
do.
listeners as
Yeah,
well.
no, I know personally, I know very little about it.
So yes, work well. It's the government have put a few £100 million into this, and the work well program is about getting people early access, so they don't have to be off work; they can be employed, but struggling at work, off work, or maybe not in work due to a health issue, and they can self-refer through to work well in the local area. It's all funded by the pots of money being given to the local authority, so the local councils, and they've set up a service then to get people early access to health intervention. So they don't have to wait for kind of the typical NHS waiting times and things like that. And they'll get access to maybe a physiotherapist or counselling or a nurse and whatever it might be. They'll get access to health intervention, but much quicker. And then they'll get that support. It'll have a work focus on it. So it'll be looking at working, supporting them back to work. It all sounds great, doesn't it?
Sounds fantastic.
There's it's only been trialed. I think there's 23 areas across the UK that's trialed it in quite small council areas. I think the idea is they're going to pilot it, see what works best, and then look at rolling it out more nationally. So that's been going on for a couple of years now. I think they've generally had some positive results, but I've not seen a lot of data that's come out from it as yet.
I guess also if it's a pocket and this is being piloted, I guess there's good reason to why many people wouldn't have heard about it. But also, I wonder how effective they have been at, making people aware, shall we say, of the availability of such a service.
I think with these services, when they roll them out, they're always a bit cautious about shouting about it in case then it takes off too quickly and they've not got the capacity to deal with it. But I think you've hit the nail on the head that is the problem. People don't know about it, so people don't use it. There's been similar stuff that's done in the past. People just haven't used it because they don't know about it. And I think they just need to go for it, shout about it. And yeah, if the capacity is not there, well, if doesn't that tell you that we need to maybe do it on a bigger scale, invest more in it maybe, which I think probably is the case. So yeah, it's positive results, but there needs to be probably more shouting about it. And the next step is they're looking at integrating the fit note into that, so that when they're seeing these people early, people are struggling at work, they'll get some early triage for some work and health support. There'll be multidisciplinary teams involved, so OTs, physios. They are looking at using some non-clinical teams as well here, so they call them work coaches, I believe. Which we can come on to, and then maybe some social prescribing, so referring to like local government interventions, like either nutrition programs or exercise programs that are run by local gyms and things like that.
Interesting.
So it's good. It sounds great, doesn't it? But yeah, the idea is that they're going to try 4 different models. That's the next steps with this reform. So in the Birmingham area, there'll still be an initial appointment, probably with a GP, to get a fit note. But then the GP refers on to this service. So that's the only input that they have. And in the Birmingham one, it's a mainly non-clinical team. So it's work coaches and social prescribing, but non-clinical team. So the GP is a gateway, but they have a kind of quite quick handoff to this team of work coaches. And they'll then complete the fit notes from there. The Coventry one, that's slightly different again. So it still has that initial consultation with the GP. But then the team that they hand it off to is a mixed clinical and non-clinical team. So it's a bit more clinically integrated in terms of the follow-up. And that's the one I like the sound of probably most, because it's a quick handoff from the GP, but also there's clinical input there, which I think is going to be much safer. And then the other two, in Cornwall and Lancashire, they don't have any initial GP fit notes. So it's a direct referral bypassing the GP to this team. I think in Cornwall, it's going to be non-clinical team of work coaches. So there's no clinical input at all in that model. Removes the GP. And the idea is, I think, that it gets that really quick intervention. I think the quick intervention is great. Just concerns me that there's no clinician input. And the Lancashire one does have some clinical. I was going to say, just to finish off, the Lancashire one has a mixed team, so there will be some clinical input there as well as the non-clinical team.
Who refers in?
Themselves. So there's no, I guess, to try and remove the barrier of having to go and see someone in those ones, the Cornwall and the Lancashire one, it's just a direct referral, self-referral.
Yeah, that's interesting. I guess. Yeah, that'd be
interesting, isn't it? I mean, I don't think they've started yet. I think they start later this year. I think I might have heard September or something like that. So these will be happening, and I think they're going to trial it for maybe 6-9 months, see how they go. And again, they're looking at which one works best, I guess. They're trying to achieve quick intervention. I think that's good. Quick intervention is absolutely needed. It just concerns me, the ones that haven't got the clinical input.
I can see two things. Simply like people being aware of the service when GP and doctors are so embedded in human mentality. You and me will see this every day. I've been to see my doctor. Doctor said A, B, and C, and when we'll have a conversation with them, also actually, we might disagree with that. We think it would be really, really good to come back to work and so forth. So we have this, and now we bring in a new entity. I just wondering how far away from the primary conscience of a human such a new service would be, that they perhaps wouldn't even be thinking of utilizing it. They wouldn't see the benefit for themselves to do so.
Yeah, is it, again, like we've said with the other interventions, it requires them to shout about it, doesn't it, and really get people aware of, you don't need to go and see your GP anymore, just get straight through to the service, really sell it as a positive. And I think if that can come across, it'd be really interesting to see how it works. But there is work to do to promote this kind of service, and being involved in setting up and running and overseeing various services in the past. That for me is a huge piece of work, and a hugely important piece of work to market these kind of changes and these kind of services before they launch. Doing it reactively, you're not getting anything through, and it's just slow and doesn't really work that way. So we'll see.
It's launching a new product. You would have to take almost like a private type of enterprise approach to it. The more you shout about it, the more it's going to sell,
Yeah, absolutely. And the thing for me is, I don't know if they're aware, but the job market's not great for graduates coming out at the minute. I think I alluded to this earlier. So it's not like there's not a clinical workforce there. We've got plenty of people that need jobs and that want or might want different jobs. So there is a workforce. I mean, that's for physio, but at the university that I'm working at, we have quite a big health course, and I know it's pretty similar for nurses and for other AHPs as well. So I think there's a multidisciplinary workforce ready there. Why not utilize them? Because they've got the skill set. It doesn't take much to upskill a clinician in how to talk about work. Asking questions like trying to understand someone's job. What is it you actually do? What's a typical day look like? What are the things that you are able to do versus what you're struggling with? Why is it that you're struggling? Having those work-focused conversations, I feel like that is not that difficult to train. And then if they're using it in practice, they'll soon become competent. But having non-clinicians, yes, they might be able to have those conversations. But what if there is a health thing there that just needs referring or some input to it? And my worry is that things won't get picked up.
Does it fit also in with the news of governmental drive that ACPOHE has been involved with in terms of getting Britain working? I think that is the naming of it. It seems to me like that seems like an integrating part of it, really important part of it. Having access to work, like let's get you back to work in a safe and sound way. That type of service seems to be so important to achieve a return to work of, what do we say, 9 million people potentially here?
Yeah, so I think the Keep Britain Working work that's been done by the government in the last few years, so Workwell that I've talked about is a product of that. So that's come out of that work. And then obviously this link with the Fit Note that's now coming into that is a product of that as well. So it's all under that umbrella and that government strategy, yeah.
Great. So you also mentioning that you had some worries in terms of non-clinical staff providing fitness for work advice. Would you mind elaborating on that?
Yeah, probably similar to what I've just voiced. Really, I think the beauty of having clinicians involved is that we'll be able to pick up if there is some serious pathology there, or there's some intervention that really does need input, maybe something urgent as well, that needs might need an immediate send to A&E or something like that. So picking up serious pathology, I mean, that's the most important thing. It's much safer to have clinicians having these conversations. But then also the rehab and support that comes with that as well. Clinicians, whether they're providing it themselves or they're just aware so they can refer to the service that's going to provide that rehabilitation and support. Really important, I think. It's a bit I've always loved of the job, really. Once you understand what someone wants to get back to and what they're struggling with, working out what movement, what exercises, what advice you can give them so that they can get to and reach that goal. And I think physiotherapists from that physical point of view, but then OTs, cognitively, psychologically, podiatrists, all of these allied health professions are going to be really good at providing that support and rehab. Whereas if we've not got that input and you've got a working health coach there, it's much more difficult to train them in recognizing those kind of serious red flags. And it's probably not safe to train them. That shouldn't be their role. So yes, they'll be able to talk to people about work, and they might be able to support people with those positive work conversations at an early stage, and that's a really positive thing. But what if there is something serious there, or what if that person does need some rehab and support? Will they be able to refer and send them in the right direction? And you need to be competent to do that. That's the problem.
There's a possibility of a gray zone in terms of law here. I can imagine it's just like legally, where would you stand if that return to work that you provided as non-clinical, practitioner with no background in health, and I don't even know where the insurance would stand there. But let's say if your advice turned out to be unsafe. And we often talk about a failed return to work. So return to work is the clinical outcome, but also you ask people, you help people back to work, but then they're not able to do so. We get that as well. And then you have the next step where there was an unsafe return to work and where things really failed. Let's say if you haven't got the foundation of clinical strong background and assessment and so forth, you could stand up in the court of law and defend your actions and your advice. I wonder where you would stand. It's a concern to me.
I don't know if that'll be that big an issue in terms of, I guess it's just not their role. They're not there to be picking up clinical stuff. They're just there to have a work conversation, aren't they? So it's maybe not that they'll be in a bad legal position, because I just don't think it's part of their role. It's more that if they're not, it's not part of their role, where's that clinical conversation coming? Particularly for those ones that they're trialing that haven't got any clinical input at all. It's just stuff not being picked up, isn't it? And it's the impact on the person themselves that could have that worries me. I guess if you've got a gatekeeper and you've got someone at least at the start that's having that conversation, they can hopefully pick stuff up and refer appropriately before they hand off to the work and health coach for the fit note input. But it's just, if people have got a health condition and they're not in work, they need a clinical conversation, don't they?
What should the us physiotherapists that are in occupational health, or physiotherapists, allied health professionals, what should they do actively to involve themselves with a fit note, and what can they do to change, I guess, the picture that you have painted at this point?
I think the first thing is if you're a clinician and you're in regular clinics and conversations with people already, show some interest in the work. And just having your head that their ability to work is such a huge health outcome, something we can't ignore, really. If you've seen people of working age, then just asking those questions, as I said before, of what is it you do, how are you managing at work, is this affecting anything at work, if so how, and what does that look like, and is there anything we could do to support, and anything your workplace could do to support, because we might be able to facilitate that. It's having those conversations, I think, is probably the initial thing. And then if you don't feel competent and need some support, I do some of the trainings, you know, as I say, the CSP have got a training, ACPOHE, we've got various training that we've done. In fact, for the CSP a few years ago, I was involved in a little project to create some resources for clinicians. So we've got like a guidance document, almost like a step-by-step guidance document on our website. We've got some case studies that we've created, and I've designed them so that you get the case study presented. It's in a video format, so you can pause it, have a go at completing a fit note, then carry on the video and compare what you've done with one that someone a bit more experienced has done, and hopefully learn from that. We've also got some awareness stuff as well for patients and leaflets and things like that might be useful for your clinics. So have a look at the ACPOHE stuff, have a look at the CSP stuff, and the DWP have got training as well. I think at ACPOHE we've had conversations about some kind of mentorship here as well, so there may be opportunities to get some direct support from a mentor. And yeah, just show interest, I think, is the first thing, and then if you feel like you need the help's out there.
Thanks, Paul. That's really interesting, and thanks for your time today. I'm aware that time is perhaps running away with us now, though. Is there anything that you would like to add to what you already said, or is there anything that we haven't spoken about that you feel is important?
No, but I guess just that it does feel like now's the time with this topic. Like there's new reforms coming in. Absence is still such a huge issue for all clinicians, but I'd like to see physios really getting involved in this space. I talked about this at a study day in the Northwest the other day, and it was really great to see how interested people were in this as a topic, and we're keen to upskill. And people recognise now, I think, that with services like Workwell, and there's another one called Connect to Work, I think the government are launching as well, there's just a real opportunity for us to get involved with it. So I think just take the opportunity, show interest, reach out for support, look at ACPOHE's resources and things, and get involved. Even if you've just graduated, I think the opportunity at any level is there. I mean, I'm involved in creating like a capability framework for physios that are in this space and working in occupational health and workplace health. Not quite there with it yet. It's a couple of months away, but I think what's going to come out is that even at graduate level, there's a role here. And it might become a little bit more advanced in terms of what you get involved with, but at any stage we can be doing this.
It's fantastic. Thank you so much for your time today. It's been really insightful.
Thanks, Lassie. Yeah, no, it's been great to share some of this, and yeah, hopefully just get a few people interested and more involved in this space.
It's great. Thank you so much, Paul. Great to talk to you, and you take care.
Cheers, Lassie. Thank you.
Excellent. Thanks, man. That was all right.
Yeah, went all right. I think it flowed.